Okay, kidney stones. This is a topic that UWorld thinks is really high yield, and I think it's sort of explained all over the place. So I thought I'd try and simplify some of it for you, or at least point out some things I think are more important for you to know. So, general overview here: calcium oxalate is the most common. You probably already knew that. And if they have an acidic urine pH with kidney stones, I always immediately think uric acid, and I'm usually right when I make that assumption on the test. If they happen to have a picture of a massive staghorn calculus, it's probably cystinuria with a history of stones since they were a kid. And they have uh, recurrent infection and a basic urine pH, then maybe you're thinking about a struvite stone with urease producing organisms being the cause. And it doesn't matter which kind of stone we're talking about, these people usually have flank pain that starts out there and then migrates to unilateral abdominal pain that usually waxes and wanes and radiates down into the groin, and it can go into the testicle or the labia. But the key here is that they usually have hematuria, either gross or microscopic, but they don't have other signs of nephritic syndrome, and their symptoms might initially look similar to gallstones, but the finding of hematuria just really almost eliminates any gastrointestinal source. And so when we're trying to uh, get started with the diagnosis and management, the biggest mistake a lot of us want to make is being conservative and trying to order an abdominal x-ray to diagnose this, but that's just not appropriate, and that's never going to be the answer on the test. Even if you think it's a calcium stone and you think it's going to show up on the abdominal x-ray and you could save radiation and money, it's not the best test. So the way we diagnose it is really they're equal. You could do a CT of the abdomen without contrast, or just a plain old ultrasound of the abdomen, ureter, and kidney. Uh, the only time when I think you have a genuine reason to do one over the other is if you have a pregnant patient. And then from there, and I'm probably giving you a little bit more than you need here, but if the stone is really small, as in less than 1 centimeter, then we could just do supportive care with pain medicine, IV fluids, or oral fluids. But some of these patients have nausea and vomiting, so you might have to give them IV fluids. And you could give them tamsulosin, which is an alpha blocker. It helps them, pee it out. And that's what you do for small stones that you think can pass spontaneously. If it's bigger, greater than 1 centimeter, in some places say greater than 7 millimeters, then you need to do something to help get it out. And usually that requires lithotripsy. And if it's real big, like greater than 2 centimeters, then you do a percutaneous nephrostomy where you put a tube into the kidney and you dig it out of the kidney, which is pretty dramatic. That's more what you do for a staghorn calculus or somebody with a big struvite stone. Now, I want you to be aware of the urgent complications that require an immediate referral to have the stone removed at that second. So somebody who's got signs of sepsis like fever and shock with a kidney stone, that's an emergency. If they have complete obstruction and aren't making urine with anuria, that's going to be a reason. And if they've got signs of increased creatinine from their baseline with hydronephrosis, that's also, we got to get that sucker out of there right now. Now, this is where kidney stones get so annoying. What do you really need to know about risk factors and prevention and treatment for the different kinds? So with calcium oxalate stones, if you're unlucky, you just happen to make more calcium in your urine, and that's a risk factor. Somebody who's had bypass surgery or a bowel resection, anybody who I believe has fat malabsorption is going to be at higher risk for increased oxalate absorption just because they're going to saponify the fat with calcium in their GI tract, and that leaves oxalate free to be absorbed. And the more oxalate you absorb, the higher the risk is you're going to form calcium oxalate stones. So people who have a diet that's high in oxalate, what foods are high in oxalate? I have no idea. So tell your patient, oh, don't eat oxalate, and they're, yeah, doctor, okay, I won't eat oxalate anymore because I know exactly what's high in oxalate. But maybe they could understand if you said a high protein diet increases their risk. This is a funny one here. People who take mega doses of vitamin C, maybe they think they're doing something good for themselves, that actually increases their risk of calcium oxalate stones. And then increased sodium intake also, or decreased water intake. And then so somebody who has a diet with low water intake or potassium intake, but here's the one that really gets me. It's a calcium oxalate stone, but paradoxically, patients who have decreased calcium intake or try and restrict their dietary calcium have more stones. So keep that in mind, that low calcium intake is actually a risk factor for more stones. And then low urine citrate promotes stone formation as well, and I do not know why. How do we prevent it? Increased water drinking, trying to stay hydrated, and calcium and potassium, basically reverse anything that was low in their diet. It's just pretty great teaching there. I just reread that to you. And then tell them that they can decrease their protein and don't megadose your vitamin C, and good luck getting patients to stop drinking sucrose and fructose, but that's a recommendation. And then people who, well, I guess what I should say is that prevention with dietary changes is the first line treatment. So somebody, they say, had their first bout of calcium oxalate stones. What's the first step in management? Dietary modifications. Got it? And then if they have repeat stones despite changes, then now we're going to talk about giving them hydrochlorothiazide to reduce their urine calcium, or we could give them potassium citrate to help increase urine citrate concentration. So, but again, that's for refractory cases. Uric acid stones, these are great. So they always form an acidic urine pH, and they don't crystallize in alkaline or neutral pH. And the risk factors in the question are usually the exact same as somebody who has gout for their joints, people who eat lots of steak and seafood like me, and people who are unfortunate enough to have decreased uric acid excretion from the kidney. Then somebody maybe who's being treated for a lymphoma and it starts chemotherapy. Maybe you think they might have tumor lysis syndrome. That's a good reason to have uric acid stones. And the abdominal x-ray will not show a uric acid stone, but you shouldn't be ordering that anyway on the exam, because the CT abdomen and the ultrasound will show it unless it's really tiny. And the management for this is pretty straightforward. We want to alkylate the urine with citrate or acetazolamide, which is a bicarbonate inhibitor, diuretic. It increases bicarbonate inside the kidney, so it's going to alkylate the urine. And you can give them dietary changes, but they're smart, they're not going to do it. And then allopurinol can decrease uric acid excretion. That's something you should know as a treatment option for these people long term. So cystinuria, this is the basic science thing here, where they have the autosomal recessive transport mutation, and they form these massive Staghorn calculi. And on the exam, this is what I wanted to point out to you, is that if they tell you that they apply sodium nitroprusside to the stone and it changes colors, then you're dealing with a cystine stone. And the treatment, trying to remember, is penicillamine in order to chelate the cystine, but you could also alkylate their urine just like you would for somebody with uric acid stones. And then struvite stones, really brief here. Just know that they're associated with infection, and you should treat the infection. These stones can get pretty big, so a lot of them have to be taken out surgically. And increased urine pH is the biggest and best clue. It's the only stone associated with high urine pH. And remember the bacteria that can do it, Klebsiella and Proteus, and there's others, but those are the two most common that I've seen. And then ethylene glycol poisoning is a fun exam topic, and the key here is going to be that one of the metabolites of ethylene glycol is oxalic acid, which has the opportunity to get into the kidney and crystallize with calcium. And then you get a picture like this showing us lots of calcium oxalate crystals. And they can form so many crystals and calculi that they acutely go into renal failure with this disorder. And the other signs of this are going to be, anion gap metabolic acidosis. They're going to be confused, probably in a coma. And the characteristic history is somebody who has a history of alcoholism, and there's something in the question about them being in or near the garage because they drank antifreeze. And just so you all have it, here are a picture of all the different crystal pictures. I hope that this isn't on your shelf, but in case it is, here's a picture so you can at least maybe review it really quickly.